Welcome to the session. I think we'll get things rolling, and if people slowly trickle in, that's fine. I'm Dr. Robert Clausen from the Children's Hospital of Eastern Ontario, and it's my pleasure to introduce Karen Fleming, who's been a registered nurse for over 20 years, and her focus is in pediatrics and leveraging simulation-based education to improve outcomes for all, especially equity-deserving groups. Karen is honored to be the education coordinator for SCAGO, as it allows her to continue advocating for people with sickle cell disease in ways that directly impact the care they receive. In addition, as an adjunct faculty at the University of Toronto, Karen is maximizing her connections by working with U of T's nursing programs to incorporate sickle cell disease information that will better inform our undergraduate and graduate nursing students around the care needs of this patient population. So I'm really looking forward to the Karen's talk about dismantling barriers using simulation in the emergency department. It should be very interesting. And at that point, I'll hand, just a couple of housekeeping things. Please, if you have questions, put them in the Q&A, and we'll definitely, and we'll save those to be at the end. We'll answer those at the end. But please don't hesitate. You can put them in anytime, and then we'll read them at the end. Okay, over to you, Karen. Thanks.
Thank you, Dr. Klassen. My name is Karen Fleming. He just introduced me, so sorry, I don't need to do that part. I am super excited to be able to be not in the back end trying to keep things going for the summit, and to be able to share about a project that really was a project of passion as far as I'm concerned. And as we get into it, I'll certainly speak more about it. So let's get started. Give me one sec here. I have no conflicts of interest to disclose. And today we will look at defining implicit bias and identify the impact on healthcare, acknowledge racism and how it manifests itself in care, participate in a virtual simulation game, and then highlight the impact of the game on healthcare providers. So I have a poll to start out. So let me put it here. Okay, so I'm launching a poll now for you guys, please, to answer. And so there's two questions there. And marketplace, and you can let me know if the poll cannot be seen, but I'm assuming people can see the poll. And it says, do you know what implicit/unconscious bias is? Secondly, do you think you have any implicit biases? And I'll just give a couple seconds to get some responses. I do see them coming in. Thank you very much. And so it's a good place to start. I'm going to ask you this question at the beginning, and then I'm going to ask it again at the end. So see if there's any. So you guys can keep doing the poll. So the next thing I want to show is a quick little video about implicit bias and how it affects healthcare. This comes from the Institute for Healthcare Improvement, and so it can be found. You can just Google it, really, if you'd like to watch it. It's 2 minutes in length. So I'm going to play this now. It just helps us set the stage for what we're really talking about today.
So in healthcare, bias comes in various forms. And I would say there's three primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations, how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews, reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is, quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the US economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
So, slides. Okay. So I just want to pause for a second and open the chat, or you can unmute yourself. When you see that video, like, how are you feeling right now? How do people feel? I just want to get some responses. I'm an educator and I've really been taught how to use quiet time. Oh, what were you going to say, Dr. Pleasant?
Oh, I was just saying, obviously there's kind of heard about the sort of interpersonal and the cost is phenomenal, that the billion, that many $1 billion per year. And I'd be interested to know more about what specific things is it about, because of poor management, there's more emergency visits, or do you know what drives that cost?
I think it's a really good question. So there are a number of factors. One of them absolutely is when you have care that is from a frame of implicit bias and you're not getting the care that you should receive, then you're coming more frequently. So there are more healthcare visits. There's more impact to your mental health, to your physical health. There might be more time off work. Maybe you need to, maybe some other ailment that's triggered by the fact that you're not getting the care you actually require in the first place. Childcare, like, I think it all goes back to the social determinants of health. And I can allow you to talk, Sola. I think it does couple with the social determinants of health, but that huge healthcare cost to me is the, inpatient admissions that I'm going to need instead of getting that primary care, and getting that primary care from a provider who is thinking from an equity lens, an anti-racist lens, social justice lens. As long as they're thinking from that lens, then I should get the care I receive and therefore not have to make many additional visits that impact from a financial perspective. If people want to speak, you just put your hand up and then I can actually go ahead and send you a message to ask you to unmute. And you should be able to unmute now, Fasola, if you wanted to.
Yes.
Thank you.
Okay, yeah. So I just wanted to, because when you asked about the video, it made me think of a situation that I experienced with my son that has sickle cell. So I brought him into the hospital in a predominantly Caucasian area, and he was having difficulty breathing and chest pains. And I said, well, could you just do, normally when I come into the hospital because my son has sickle cell, could you just do like a CBC and a blood culture? That's all I'm asking. And they said, no, we don't do that. Why would we do that? And then they sent me home. They said, he'll be fine. Go home. I came back the next day because it became worse. And I asked the same question and they said, no, he's fine. I said, I don't think he's fine. Please, can you help my son? And again, they sent me home. The third day I now came in, same experience. So then I left from that hospital and went to a hospital in a different area. And they said to me that if I had gone home, my son would have died. And sorry, I don't mean to get teary. So from that experience, I had even asked them inside the hospital. I said, like, if I call sick kids and talk to the hematologist, and the hematologist tells you, will you, do this for me? And they said no. And but from that experience, when I went back to sick kids, the nurse that was there, I believe that she contacted that hospital. And the next time I went back to that hospital, they listened to me, and they were different. And yeah, so I just wanted to share my story. That was it. That's what that brought to my mind.
Thank you, Fisola. I appreciate, you being brave twice today, sharing your story, and the impact. I could hear it in your voice, and I don't know if others can hear it in mine, that bit of shaking. It's that whole, I just wish it was different. I wish that we're trying to make that change happen. But I really just wish a lot of our families just didn't have to go through this. Any family of any condition at any time. And so I'm gonna take the opportunity to answer this question as we go, simply because I want this to be interactive. I do want it to be one where we can ask questions, and we'll definitely get to play the game. Isn't it counterproductive to not treat us properly in the first place? Doesn't it cost the healthcare system more money under treating us? And Patrina, I agree with you 100%. That's that $310 billion per year. And if it's in the States, I think we can all appreciate if it's in the States, it's in Canada. This is something, to me, wherever individuals with sickle cell are living, are experiences that they have in one capacity or another. So yes, I agree with you. And that's, I think, also one of the huge messages that was coming from that video, is he was trying to highlight to our governments, to those that are about the cost, that this is actually costing more money. So I thank you guys for sharing so I'm hugely about facts. And so I want to actually start off and position how did it come to be that I created a virtual simulation game. And I'll tell you about the game itself. So I've done my master's in nursing, and the second degree I've really looked into was the master's of simulation a master's of science in healthcare simulation. The reason I really looked into a healthcare simulation degree is because I truly believe simulation is one of the only ways. I actually feel it's the only way, but I try to be really open to something I don't know. But there's so many different types of simulation. So I do feel that simulation-based education is the way forward for helping healthcare providers in being able to retain information during times of stress and anxiety, that we can use simulation to help continuously expose ourselves to these situations in safe environments. So when we're faced with it, we really know what are the first steps. And in the case of my virtual simulation game, it's not an emergency situation. In fact, it's a situation that individuals with sickle cell face, I want to say, every day. But we have heard it over and over from patients who are here about their experiences. And so the first article, Patient Perspectives of Sickle Cell Management in the Emergency Department. And so as a part of my degree, I had to do a capstone project, or I had to do, a big project at the end. And I wanted my project to be meaningful. I wanted to do something that A, I could finish, and B, that I could take and do something with it and it be meaningful. So my mind certainly went to sickle cell first. And then I wanted to think about, well, what is the gap? Like, does simulation fill the gap? We don't always need to use simulation just because it exists. Does it actually fill the gap and the need we have? And we've heard it here too. Lack of healthcare provider education. That is one of the biggest gaps that patients state, that healthcare providers state. There's healthcare providers who are looking for education, but it's not embedded. It's not embedded in our nursing school curriculum. It is not embedded in medical curriculum in a capacity in where I can care for a patient who comes into the emergency department. You'll find out sometimes about it being a red blood cell disorder, and generally somehow linked to that it's a Black people's disorder. That tends to get coupled to it when you're doing this broad overview. But our schools don't really get down to the inequities that exist for this patient population and our contribution to it. And how do we reduce that? How do we change the narrative? And so therefore I had to do a lit review. And so there's a number of pieces of literature. I just pulled up the top 3, and I pulled up one, that's patient focused. I pulled up one that is nursing focused. And then I put up one that is it's not medical focused. It's more about language, but it was an article that was about authors. So the first article, Patient Perspectives of Sickle Cell Management in the Emergency Department. So this is from 2021. So it's not old, right? Just last year. And the key findings, varying analgesic practices of providers. And we've heard that too. I've heard that in the session. That depending on which provider is on, it would vary the level of care they would get. Provider bias, right? So implicit bias, we just got to be introduced to that. Lack of provider knowledge. Delay in care upon presentation to emerge. Right? So we heard this too. We heard about how long sometimes individuals are waiting. And we also heard about great projects happening, such as UHN, and looking at how do we get that first dose of opioid to an individual with sickle cell within 30 minutes. Emerge is a last resort. I hear this a lot. I speak to individuals with sickle cell quite regularly. And I hear this a lot. They wait. They wait, even with encouragement. Okay, so sometimes, as a nurse, you get tapped on the shoulder, as we know, to be asked for advice. And although our advice makes sense, their hesitation in going into that emergency department is the experience, their previous experiences, those previous negative experiences. And do I really want to deal with that? So our patients are coming in really late, and they're coming in really late to avoid the racism, the discrimination, the delay in treatment, being told that, you don't look like you're in pain. Well, what does that look like exactly? I'm sure as healthcare providers, we all know, if I ask you to type in the chat, as healthcare providers, what are we told pain is? I think I'll do that, right? So I know there's some healthcare providers. I see you guys. I know there's some healthcare providers. What is the definition of pain? Just one person pop it in the chat. Just entertain me. If it can't go in the chat, throw it in the Q&A. Okay, so while we wait for that, it's all about listening to the patient. Omission of outpatient prescriptions. When I read this, I was actually and or outpatient follow-up appointments, not completing the circle, refusing to prescribe medications, and not ensuring that there's a follow-up appointment connected to this acute episode. And then inconsistent access practices. I've heard this too. IV versus sub-Q, intravenous versus putting it into the subcutaneous tissue. They're two different methods. They're two different nursing skills. But they're nursing skills that if we don't have them, then we need the opportunity to practice them. But I've heard some say, well, I don't know, sub-Q, we don't use it very much. So then competency is an issue. So for the order set, let's only offer IV. And IV access, in my experience so far, it has to be one of the most challenging things when an individual with sickle cell comes in. They're in pain, most likely dehydrated, and you're trying to get access. The number of IV access attempts, I really want to do a study once. I'm saying, really, a study on how many IV attempts were made for you in the emergency department to get your access. And then let's compare that to others, because I think for what I've seen, I just think we have more opportunities. And thank you, Priscilla, for confirming. And in red, 60% stay home to avoid the merge. 60%? Are we okay with that? 60%. Over half of individuals with sickle cell who know they need to be in the emerge stay home. No, that's not okay. 50% satisfied with care. We're just saying basic, you're basically, I'm just satisfied with care. Only half. Okay, so the next article was Nurses' Attitudes Toward Patients with Sickle Cell Disease, a worksite comparison, 2015. And I want to also mention to you guys, all of these articles, these 3 anyways, they are attached to this particular session. So later, after, you can always go to the session description. And what I attached there was these 3 articles, and I attached the PDF to the poster for the virtual sim game I created. I've also presented it as a poster. So there's more info in there. So it's just something you can take with you and zoom in and look at it at your pleasure. So those things are attached. And if you have issues, just let me know. Okay, so for nurses' attitudes, Like even the fact that there is an article named Nurses' Attitudes Toward Patients with Sickle Cell Disease lets you know it exists. Right? Do you see articles? And I won't get deep. I'm trying not to get too deep because I definitely don't want to run out of time. So let me keep moving forward on this one. Cue recognition and cue response are not aligned. Okay. What that means is the patient gives a cue of what they need. That's that is the, the recognition of it. Sorry, I'm so sorry. The patient gives a cue. The nurse is meant to recognize that cue and say, okay, I can see that the patient is in pain, but my response to that recognition are not aligned. What I'm supposed to do based on what I recognize are not aligning. There's some disconnect. And this is due to previous negative experiences in eMERGE. Patients are perceived as drug addicts. We've heard this a lot. Reluctance to administer opioids. So nurses have a reluctance to administer opioids. And I wouldn't just say nurses, okay? So let me, even though this is a nurse article, I would say healthcare professionals are reluctant to administer opioids in fear of contributing to addiction. But since nurses are the ones who physically give the medication, there is that fear. Through some of my work I did at North York as a sickle cell advocate, and when I was able to go from, patient to patient, and then I also was able to share with nurses, I was able to go to them and make suggestions around what we should do, because it's a team. There was reluctance, and you heard it, like actually it came out, like it was audible, it told it to me. So not only is it a feeling, it's such a feeling that you feel comfortable enough saying it, right? We only feel comfortable saying things that we feel are true. I feel, if I give you more opioid, I'm only going to make your addiction worse. But if you listen to those words, that is implicit bias. You are convinced that I am an addict. And so through that lens, that's how you're treating me. There are articles that show you, I didn't even pull up this one, the opioid crisis article. Just being diagnosed with sickle cell alone can, in some people's minds, automatically triggers opioid crisis, opioid addiction from the opioid crisis, which raised so much awareness around opioids and raised so much fear in us too. As healthcare providers, I want to ensure that I'm safely caring for my patient. But we need to do that through a clear lens. We have to ensure that we're not taking what came out of an opioid crisis and applying that to every patient we see, and especially a patient population where opioids is their main treatment. That is their main treatment to I don't even know if relieve the pain is appropriate, to take the pain, some of it away. There's nurses who have lack of sympathy, look too healthy to be sick. You look too good, right? The cell phone thing comes up. I have it again too. You're on your cell phone. Someone definitely mentioned it about the pain could be actually so bad. It could be only increasing that now, you're pulling out everything I can to help me cope, whatever I can do. And it takes too much nursing time. I've heard that too. I've been in organizations where patients are, units, they're trying to shift patients off their unit to another one. It's a lot of nursing time, a lot of nursing work. We kind of need to share the wealth here and move this patient to another unit. What? When do we do that for other patient populations? Why is this okay to talk about when we're talking about sickle cell patients? Why is this a choice? It's not a choice. That doesn't make sense to me. The patient is here. If there's a discomfort with the care, call on us, the sickle cell advocates. We will come to your unit. Okay. Part of the reason I started the sickle cell advocates in collaboration with other nurses at North York General was because we needed to bridge the gap and help in the immediacy of education while we move through the red tape of getting formal education across the organization, whatever that looks like. We needed something immediate. And so we were at the bedside. We got an email when the patient arrived, and we found them within 48 hours and asked them about their experience and how could we help. We didn't have anyone tell us that. Literally, I just guys, I think we should be sickle cell advocates. Let's do it. That's really how it happened. So you need to be in the right position. And I have to say, as part of, I do really think my role as professional practice leader allowed me to maximize the opportunities to move the needle forward. for sickle cell. So I'm gonna, the last article, because I can see now that my time is running by me fast. So let me share this one. Do words matter? Stigmatizing language and the transmission of bias in the medical record. This article also really speaks to, I remember Renee was also speaking, Renee Bailey was chatting about the project they were doing at UHN and how language can just make such a difference. And so this article speaks around providers, and dependent on what they're writing in the medical record, will transmit to someone their training, because then they take that implicit bias that is within the medical record, and they then that helps inform their thinking and helps inform their practice, because then whatever they wrote informed what they did as actions. Okay, so hidden curriculum meaning the words without meaning to share a perspective, they're doing so in impacting the actual actions of our providers. So my virtual simulation game is a digital recreation of authentic clinical situations for safe practices by nurses, and supports the use of clinical reasoning for users as they navigate the patient's scenario. It's based on Kolb's experiential learning and reflection on experience. So I won't get deep into the educational framework, but it's based on an educational framework. That's one of the, it's based on an educational framework, and is one of the reasons I truly moved towards the virtual simulation game. It is accessible. This one is based on an educational framework, and it really hits all three domains of learning: your cognitive, your psychomotor, and your affective domains. The design principles that were used: unsettledness, authenticity, scaffolding, and feedback. What I want to further say about this particular game is I did ensure that I included a patient. I wanted to be authentic to the experiences that were going to be shared within the game, as the game is deliberately filled with implicit biases here and there, and very clear experiences of individuals with sickle cell, in a way that if you select the wrong answer in the game, you will see what the reaction is of the patients, and therefore hopefully know that you're going down the wrong track. And not hopefully, because in this game, if you get a question wrong, you are pushed back to the top of the question and you must answer it correctly before you can move forward. That is something else I made deliberate to ensure that the learner, as they get to the end, that you know what are the ideal steps when it comes to your care that you're meant to provide to an individual. So we can play a little. So I'm only going to do one question, because I can't show you the whole game, because then, so I'm going to show you guys one question and show you how the game works. So you can see here that I did make this game in collaboration with North York General, and then my school, the University of Alabama at Birmingham. And thank you, Fitzanne. We've seen Fitzanne with her blue hair here all day, all weekend. And I'm thankful to her for sharing and being open to contributing, right? She saw action. She was really happy to participate in this. And to know that we tried to check in with her often to think about the re-traumatization she could be going through as we created this game. And I think she saw, I think there's a number of things. She saw the script before the game. I engaged her before we were taping, and just really her knowing that it's for the education of healthcare providers, I think kept her in a positive mind space. At the top, the learning outcomes are there, but as the learner enters the game, you'll see the development team. So I thank all of my colleagues. I thank, Rashenda Hayes is online. Thank you very much, as well as she will embed the use of this game in the emergency room education for nurses at North York. Okay, how the games works. You don't need this right now. The accessibility statement, you don't need that right now. And so we're gonna put ourselves in Summit 2022. Okay, so we begin the scenario. And so you want your learner to be successful, right? So tell them, what do you want them to learn? You don't need to hide it, tell them. Okay, so here's the learning outcomes. You will see clearly that number 4, identify the impact implicit bias can have on the healthcare experience of patients diagnosed with sickle cell disease throughout their hospitalization. Right, this game is not like apply it to sickle cell. No, it is straightforward about sickle cell disease. So you get a case summary of the patient. She's a 30-year-old female diagnosed with SCD who has arrived at our community hospital emergency department in excruciating pain related to a VOC. She has been scored CTAS level 2, which we know is the requirement, because I didn't want to distract people with that, right? So CTAS level score 2, that's correct. And she's currently in an acute care room waiting for the nurse. You're now walking into the room
Donkey.
to introduce yourself and meet your patient. And so visually, I let them know what level 2 was so that we know level 2 is like emergent, one level away from resuscitation, right? Okay, so here we go into the game.
Hi, my name is Lloyd Francis, and I'll be your nurse in the emergency department today.
I'm in so much pain. Can you please help me?
Yes. Is it okay if I complete my assessment first?
Sure.
Okay. So then the learner would be at this particular spot. And the question would be, what are the priority components of an initial assessment for a patient with sickle cell disease presenting to emerge with a vaso-occlusive crisis? Select all that apply. And so if anyone wants to tell me that what they think they would say, absolutely, you can tell me. But I also want to keep us moving. So I want to show you the incorrect answer. And so sometimes people will think I need, right, vital signs, that I need to also do a head-to-toe assessment. Well, I definitely need to get a pain score. And you know what? Let me figure out what dose of opioid has worked in the past. Okay, so I'm going to select this and I submit. So to remember, you get, if you select the right answer, you get one video. If you select the incorrect answer, you get a different video. So it tells me, oh no, that wasn't the right response. Uh-oh, you know, what happens?
Hey, Shauna. I have your morphine here as ordered.
Didn't you read my chart? It's supposed to be hydromorphone. Hydromorphone is the only thing that controls my pain.
And so then also ensuring that we let the learner know what is it that the right answer was meant to be, right? When collecting the history of a patient diagnosed with sickle cell, presenting with vaso-occlusive crisis, it is important to note which opioids have provided the most relief in the past, at what dose, and at what frequency, and that discussing the home regimen before arrival is also essential. And so if you return to the question, it will give you a chance to answer it correctly now, and then you'd see the other videos. Pain score, I got to do the pain regimen. I definitely have to do my vital signs, and I have to do the dose of opioid that has worked in the past. What I want to highlight here is a head-to-toe assessment is not essential. This is about priority. Initial assessment. I actually do not need to do a head-to-toe assessment before I approach the MD to get a dose of opioid. And that was really one of the driving points here. And I did have, also I want to say I did have an expert look at mine as well. So congrats, you're off to a great start. So here's your video. So then you move into question 2. I'm actually going to pause because now you're just moving into. So after, there we go. After you did answer that question correctly, let me just go up a slide and then I'll explain the data that's up there. After you were able to actually get into, if you selected the right question, it moves you along in the game. So then you would have seen the chart was up and you're starting to now look at the vital signs and you're starting to do your assessment with your patient because you brought them the right pain meds. You know, when you didn't do the correct assessment, perhaps you didn't actually listen to everything the patient had to say, or you didn't look at the chart, and that's why you came with morphine instead of hydromorphone, which is what works better for your patient. So now they got to wait again for you to go back out, get the narcotic keys, you know, all this process. And it might not be keys, but there's a process now that I've got to get the order changed, etc. So hopefully, you know, we can avoid this by first of all, just listening to our patient up front. I am very excited about my results. Okay, good. I feel like I got 5 minutes still, Robert. If I don't, tell me. Okay, so what percentage of patients with sickle cell disease? And so these questions, just so you know, came from a tool I used, which is validated and it's also reliable, meaning that there's some scientific rigor to it. It's a tool anyone can pick up and use, and it has already been tested. This tool is targeted to those in eMERGE. So it's specific for sickle cell disease healthcare providers in eMERGE. And so on the left-hand side, you will see over-exaggerate pain is yellow and that drug seeking is green. Before people played the game, sorry, I didn't tell you, sir, I had 20 individuals test the game first, okay? So emergency staff, nurse educators, I had an e-learning specialist, a quality improvement specialist, a patient. So I had a range of people test the game. Before, on the left, you'll see the yellow bars are kind of over. You see, you know, less than 5%, the 6 to 20%, the 21 to 50%. You can see that the yellow bars, most people are on the left, and same with drug seeking. That kind of spreads across from each of those towers. If you compare it to after, what you can clearly see as a difference is anyone, for example, who's in the 21 to 50%, meaning that people who took the game felt before they played the game that 21 to 50% of patients over-exaggerated pain and were drug seeking. And after they played the game, those that were in the 21 to 50% category are gone. So that had to be 2 or 3 people moved over to the left, and that's what we want. We don't, you can't get everybody into the less than 5%. We just want to see a shift. So let's see another shift. Okay, so please indicate your opinion about the degree to which each of the following is a sign that a patient with sickle cell disease is inappropriately or unnecessarily drug seeking. Okay, and yes, the question does imply that implicit bias exists, but that is because the implicit bias exists, right? So what we're trying to do is get everybody to strongly disagree with this. So you'll see yellow on the left, request a specific narcotic drug or dose, right? So an individual comes to the eMERGE and says they know exactly what dose they need and exactly which name of drug. Wow, I've only been living with sickle cell my entire life, so that's really reasonable. But that is a sign of you, it could be interpreted as a sign of drug seeking. And so the yellow bar, right before they started, you can see there are people who strongly disagreed, disagreed, neutral disagreed. And so the actual yellow line spreads across all the indicators. But after the game, you see the green line is nicely pulled to the left and everybody's in the disagree, right? Like it truly warms my heart. I like this game help people to see that, and does that translate to practice? That is the question. The next one appears comfortable. See this one, talking on the phone or watching TV while complaining of severe pain. Yellow bar again, you see it goes from strongly disagree right over to agree. Now my green bar, you can see it still gives you some agree, but you see that the yellow line has dropped. So not as many people as agree, and you can see it also has shot up. So there's more people who have moved to the left. So we want just people to move to the left and change, have a change in your thinking because our thinking informs our actions. Inadequate pain management by doctors and nurses. Do you feel that many patients with sickle cell disease who exaggerate pain do so as a result of that? And so this one, the yellow, same thing. This one only a slight change, but it's still a change. I'll take any little bit. So you'll see there was, about 6 people who were neutral agree and about 1 person who would strongly agree. And you got about 10 people who were way up there, we agree. And then we shifted over a little. The green has shifted a bit. So we took somebody and we helped them to move towards more agreement. Regardless, everybody agrees that healthcare providers contribute to that. So if an individual with sickle cell disease exaggerates pain, what do you think contributes to that? Healthcare provider poor pain management, it's there. A perception among patients of the need to act out in order to get appropriate pain medication. Same situation here. Everything shifted to the right to show more agreement with the perception that we feel patients have this perception. And patients have reported feeling they need to do that in order to get the pain management they need, because people don't believe them when they just say, I'm in pain, right? That it actually has to be something really, I don't like the word aggressive, but it has, where you're actually, to me, perpetuating the stereotype, and we won't get deep into that, but I don't think you should just be able to state what you need. And that's it. I shouldn't have to act out. I shouldn't have to think about how do I have to act. I just be myself. The last thing that's really important to me to highlight is comfort and knowledge. Healthcare providers, as people, really, if you increase your knowledge, you tend to be more comfortable with something. So this graph shows the yellow bars. I don't even have to go through numbers. You can see that the yellow bars were spread all across for comfort on the left, and you can see that there's more green bars to the right. So the green bars are after they did the game, there was more people who had increased comfort. You can see that the yellow, there's nobody over at 0, 1 area. The lowest number is a 2. And you can see that the 8 went way up from 2 people up to 5 people, increased comfort. Same with knowledge, right? I'm loving this one. That there's green, the 8 again, nice and high, that we had some that felt their knowledge was like a 1. There were some people who weren't even clinicians. I had a non-clinician say this. And you can see the lowest number someone gave around knowledge was a 6. That's what we want. Okay. These are quotes which I'll leave on the slides on the screen for a moment, because I do feel, yes, that I am at my wrap-up time. These were the words from healthcare providers after they played the game. And it's all you want. You just want people to cause me to think beyond the basics and to think deeper about the needs of a sickle cell patient beyond just giving pain meds, because we talked about other therapies, the 3 Ps of pain. Yes, we talked about it in the game. I'm going to pop up the poll and then questions can come up. I have a post poll, which I'll launch, and then questions can also be done. But there is the post poll. Thank you guys very much. Oh, my business. Okay, fine. Yes, started my own business, simulation consultation, anyways, and sickle cell consultation. Thank you guys.
Karen, that was a fantastic presentation. I'm just conscious of time. We're supposed to finish at 10 past, but I noticed that the coffee break doesn't start until 1/4 after, so I'm going to take advantage of those extra 5 minutes for questions, because I'm sure there's lots of questions. Some really interesting questions around people who, when they're in pain, using laughter, or which is seen as inappropriate, but they use laughter as a way of coping and to find relief. I don't know if you have any comments about that.
The funny thing I would say, honestly, is I think the best person to ask sometimes is the patient themselves. I think that patients can use a range of things. If it's laughter and that's what works for you, I think we need to know that that's what works for you, so that we know directly as we're trying to do our assessments that sometimes, you know what, I laugh when I'm in extreme pain, but it's the only way I know how to cope, because I would think if you're telling me your pain is an 8 out of 10 and you're laughing while you're telling me that, I can see the miscue. I can see them, you know, that cue recognition and the cue response, that they may not align. So I feel like that needs to be shared with your providers.
There's one story about a parent with a 3-year-old who had trouble getting IV in the emergency department, and the nurse not asking for help. I don't know if you can, and it left their son traumatized. I don't know if you can maybe talk to that point.
I think it can be difficult to speak about separate experiences that individuals have in the emergency department or in any department where, you know, IV access can be a challenge. You know, could they have been the most senior nurse on, so there really wasn't anyone to ask? You know, could it be the department truly was that busy that this nurse was just really wanted to try their best to get it on their own because they knew you'd be waiting and waiting and waiting before another nurse could come? It can be so many different factors happening at the time. What I would say is I believe most organizations have a policy about how many times are you meant to attempt per provider. And I think that that is something that you could explore before you know, I don't think that there's anything wrong with that. Before you do my son's IV, I'd like to know how many times will you attempt before you ask somebody else to give it a try if you can't get it. Like having a plan B, like I feel that's quite reasonable. And if they feel confident and they're going to get it, you know, after maybe 2, because 2 tends to be the number, I didn't tell you that, but 2 tends to be around the number. So like, don't state, because every organization is different, right? So I'd say asking questions and advocating for your child and about what works well for IV starts. Does it work well when whatever? Share whatever those things, like whatever you see when an IV's gone well, remember those points, jot them down somewhere. And so when you come back in, this is what went well the last time. The nurse did lied him on his right, whatever it is, that will be very helpful to us, I think. Thank you for that question.
Yeah, very good question. There's another comment about pain being, it's a subjective experience, and the problem, the issue with that is then the healthcare provider applies their own experience and expertise about what they really think is going on. So I know you've kind of talked a bit to that, but maybe you can elaborate more on that issue.
So we agree pain is a subjective experience, and as healthcare providers, that's what we're taught. And even more so, we're taught self-report is the most reliable method. So I'm a little conflicted, to be honest, because you're right. Whatever the patient says is what we should listen to, and then we should make our treatment decisions on. Implicit bias changes that, right? Implicit bias can, because we all have implicit biases. And thank you for answering the poll. Awesome. went from, you know, not everybody knew, and at the end, everybody said yes. So, right, you're going to leave here today being clear on what implicit bias is. And so I think that what the question is ensuring that when we are providing care, that we are not doing it through a lens where our implicit biases are impacting the care we provide. That's the, you know, I don't know if that really answered, but
Thank you.
I know it's subjective, and I agree with you. And I think there's more work being done around, because even the pain tool, like we won't get deep into this either, even the 1 to 10 scale, there's some literature around there, like, is that really appropriate for individual sickle cell? Like, does it really meet their needs?
There's a question about, from one of the attendees, has this educational approach been implemented in acute care hospitals? And then if not, how would hospitals engage in bringing this to their teams?
Thank you. So I would think North York's probably one of the only places, and I'm not sure how far it's gotten. I've moved to another organization, but the organization, like literally for the game, if they just want to email me, they can just ask me, like, here's the game link, right? I just don't put the game link publicly because I do want to see where is it going. You know, Mohawk University, for example, is going to use it in their med-surg curriculum. At U of T, I'm going to have it embedded in the undergrad, and it can be something referenced for the grad curriculum. So I think for hospitals, reach out, ask me. They can reach me through education@sicklecellanemia.ca or Karen@seamlesshealthcareconsulting.ca. And I can provide it. I have no problem, but the organization has to be ready, right? They have to be, like, it's there, but they have to then, like, what are you going to do? You're going to make it mandatory, et cetera, et cetera.
Great. And then I think one of the final questions is about if you're going to translate it into French or other languages.
Oh, my game is available in French, I want to say.
Oh, is it? Okay, good.
I'm pretty sure, because I worked with CanSim, the Canadian Association of Nurses in Simulation Education. I feel like they told me that, honestly. So that's just a little, if you want to email me privately, you can, but the game is available in French. I feel fairly confident about that, because it's one of the things I was excited about, was that this game would be able to be used across the nation if anyone was.
Well, I'm just thinking that you used an English patient speaking in English, so I don't know if it probably would be, you know,
Voiceover.
A voiceover is maybe not the same thing as actually using a French francophone patient. So.
I agree, right? So whether that is, you know, if someone thinks about, because there's a lot of coordination, right, to pull that off. But if you have a French-speaking patient and you're looking for guidance on how to create the game, absolutely. Like, I can provide that. It's about resources. So if you've got some resources on your end and you just need some guidance on how do I structure and do what you did, no problem, just contact me.
Well, thank you very much. This is very, very interesting, very educational, and it's wonderful work. And I think at this point, it's time for a coffee break. So we'll let everybody get off and grab some coffee and put their feet up before starting the next sessions. I guess in a half an hour time.
No, it's 2:25. Yeah, in 10 minutes we have.
Sorry,
yeah.
2:25. 10 minutes time. Oops, not a half an hour. Sorry. Oops.
Please.
10 minutes time. You don't get to relax that much. Okay.
Awesome.
Anyways, thank you so much. Great.
Thank you, everybody.
Bye-bye.